Greetings from Cape Town, everybody. I'd like to start out by thanking the Scientific and Organizing Committee for inviting me to contribute to this important meeting. My name is Mpiko Ntsekhe. I'm a cardiologist at the University of Cape Town and Groote Hospital. So today I'm going to be discussing HIV as a risk factor for cardiovascular disease with a focus specifically on heart failure. So what I'm going to do basically is briefly review the cardiovascular diseases whose risk is significantly altered by HIV, and then focus on HIV-associated heart failure with a look at risk, impact of geography, evolution of the phenotype over time, and examination of potential causes. I'm going to further describe ongoing local research on preclinical structural and functional abnormalities in ART-treated people living with HIV and present some of our preliminary results. So there's 6 predominant forms of cardiovascular disease in people living with HIV. Atherosclerosis is most common form of heart disease, with coronary disease, peripheral vascular disease, and stroke encountered in the developed world. In terms of risk, HIV doubles the risk compared to uninfected controls. Now, although rare at 1 in 200 patients, HIV-associated pulmonary hypertension is about 1,000 times more common than in the general population, and it doesn't look like ART has altered this risk over time. Then large vessel vasculopathy is a rare entity found almost exclusively in sub-Saharan Africa and manifests with aneurysms of the aorta and branches of the aorta. And then what we know is that patients with HIV, with or without ART, are at significantly increased risk of TB pericarditis in TB endemic areas. Interestingly, the risk of constrictive pericarditis is significantly reduced in those with HIV. And then more recently is this exciting publication or interesting publication showing that HIV is an important risk factor for sudden cardiac death. It was a post-mortem study demonstrating that the incidence of sudden cardiac death in people with HIV compared to matched controls is almost doubled, with a 25 per 100,000 patient year incidence in those with HIV versus 13.3 in those without. Also of note is that they found higher rates of myocardial fibrosis as the arrhythmogenic substrate for sudden cardiac death. And as you'll see later on in my presentation, this has important implications for heart failure. Now, the burden and phenotype of cardiovascular disease in people living with HIV in the ART era appears to differ significantly by geography. Those arrows point to North America and South America, where atherosclerotic cardiovascular disease predominates. However, as people live longer with coronary artery disease, or in spite of the coronary artery disease and other traditional risk factors, it's believed that the burden of heart failure will steadily grow and may become dominant over time. Whereas in sub-Saharan Africa, where the vast majority of people with HIV live, heart failure is unequivocally the dominant manifestation of cardiovascular disease. This point as it relates to sub-Saharan Africa is illustrated by this study led by Karen Sliwa at the University of Cape Town of 515 consecutive patients with HIV admitted with de novo heart disease to South Africa's largest tertiary care center and hospital. The age of the cohort was had a mean of 40. Most were men, and about 50% were on antiretroviral treatment. All underwent full clinical evaluation, including echo and angiography to rule out coronary disease. What you see from this pie chart is that about 2.7% of the patients had coronary artery disease-related admissions, and the vast majority, i.e. 37%, had heart failure from heart muscle disease. Now, heart failure with reduced ejection fraction was more common than preserved. Now, case reports of patients with advanced HIV and AIDS presenting with dilated cardiomyopathy and decompensated heart failure were recognized very early in the HIV pandemic. However, Combined antiretroviral treatment has really transformed HIV, such that the 15 to 20-year survival is now close to 85% on modern therapeutic regimens. And as survival has improved, the phenotype, causes, and burden of heart failure has changed. So if we look at the evolution of the heart failure phenotype, what you find is that in the pre-ART era, it was predominantly heart failure with reduced ejection fraction driven by high viral load, infectious myocarditis, and toxic drugs, including some of the antiretroviral regimens of that time, where people had access to them. Now, in the post-ART era, where the majority of patients are on antiretroviral treatment, what you find is that heart failure with preserved ejection fraction is the dominant phenotype, and it's believed, although this hasn't been proven yet, to be driven by traditional risk factors and persistent immune activation. With regard to HIV as a risk factor for heart failure, since 2011, there has been 4 large observational studies designed to determine the risk of heart failure in this group of patients. All have been conducted in North America. 2 were prospective cohorts, and 2 were analyses of large healthcare system databases. The message from all 4 studies was essentially the same, and after adjustment for patient demographics and their cardiovascular risk factors, what the findings show is that HIV approximately doubles the risk of heart failure, that amongst those on ART, the risk is greatest for heart failure with preserved ejection fraction. And although HFpEF is much more common, the risk of HFrEF, or reduced ejection fraction, remains significant at over 50%. High viral load, low CD4 counts at onset of antiretroviral therapy remain important determinants of risk for both HFpEF and HFrEF. With regard to causes of heart failure, the potential causes of impaired cardiac function in those with HFpEF are also under investigation. Now, amongst those without coronary artery disease, 2 potential causes stand out, and they include myocardial steatosis and myocardial fibrosis. So with regard to myocardial steatosis, it's important to understand that the prevalence of non-alcoholic associated fatty liver disease in patients with HIV on ART is between 30 to 60%. Now, the reasons for this high prevalence are multifactorial and believed to be related to the high rate of co-infection with hepatitis C, some of the metabolic derangements associated with the antiretroviral therapy, and obesity itself. Now, importantly, NAFLD, as it is called, is associated with an increased risk of HFpEF. So you can see why myocardial steatosis is an attractive target to look at with regard to causes of myocardial dysfunction. Now, using MR spectroscopy, 2 studies suggest that people living with HIV on ART have significantly more myocardial lipid content and steatosis than matched controls. To date, no correlation with markers of abnormal glucose or lipid metabolism or HIV disease itself or the antiretrovirals were found, but the studies have been quite small, and it's possible that they were underpowered to detect such subtleties. Interestingly, Zanini and colleagues from the United States have recently replicated these findings in a subset of participants recruited to the global Reprieve trial, which is a randomized trial designed to test whether statins can reduce the rate of atherosclerotic cardiovascular disease in patients with HIV. So having found this, it'll be interesting to see whether statins compared to placebo are able to reduce the incidence of HFpEF in the main study. With regard to myocardial fibrosis, 3 recently published CMR studies suggest that there is increased myocardial inflammation and fibrosis in people with HIV relative to their age and gender matched controls without HIV. All of these studies have been conducted and published in the USA and UK. Now, with this in mind, in 2017, we applied for and received NHLBI and AHA grant funding to establish a research program to investigate myocardial fibrosis and inflammation and its determinants in patients with HIV in South Africa. The study and the program is called the HIV myocardial fibrosis program or study. For context, it's important to remember that for patients with HIV on antiretroviral treatment have a high burden of hypertension and obesity, tend to commence their antiretroviral treatment at a relatively low CD4 count, and have high rates of background opportunistic infections such as TB prior to commencing their antiretroviral therapy. Now, these factors may predispose patients to longer duration of systemic inflammation, high levels of systemic inflammation, and immune activation, fueling myocardial inflammation and fibrosis. But whether or not there is CMR evidence of preclinical structural and functional abnormalities remains to be determined. So the study hypothesis for the MyFi study, as we call it, is that myocardial inflammation and fibrosis, as determined by CMR in asymptomatic patients with HIV, is high compared to controls, is driven by this immune activation and monocyte-induced myocardial injury, and probably correlates with biomarkers of cardiac stress and injury, and specifically BNP and troponins. And that this myocardial injury forms a substrate for the risk for future heart failure. The study is being conducted in Khayelitsha, a 2 million strong township outside of Cape Town, where the HIV prevalence is estimated to be about 35% in perinatal surveys. The burden of TB is amongst the highest in the world, and the prevalence of hypertension is about 35%. Obesity in women is at a significant 30%, and this multimorbidity, as you can imagine, forms the basis for which inflammation, immune activation, and high rates of myocardial inflammation and fibrosis might take place. So what are the results, preliminary results from the first phase? Well, to date, we published the first phase in which we had enrolled 255 studies, and after exclusions, had complete data on 134 patients with HIV and 95 controls. Participants with and without HIV were well matched except for the HIV-specific variables. So the age was around 50, it was predominantly female in the mid-60s. The BMIs were a little bit under 30 in both groups. Hypertension was highly prevalent. Diabetes was under 10%. And in those with HIV, a history of TB was actually quite common at 55%. Patients had had HIV for about 10 years. They had been well treated. Most had a duration of antiretroviral treatment of 7 years. 16% had a prior AIDS diagnosis, and close to 30% had a nadir CD4 count of under 200 when they commenced their antiretroviral treatments. What we found is that there was a significantly greater degree of fibrosis as measured by extracellular volume on CMR in the 132 patients with HIV compared to controls. Interestingly, the prevalence of late gadolinium enhancement was also quite high as 73% in both groups. And the finding of such a high LGE in our controls was completely unexpected. There was also no correlation with BNP and troponin, which were not elevated in both groups, probably reflecting that most of these patients were asymptomatic. The immunological analysis is pending and should be published soon. We further found no evidence of abnormal systolic or diastolic dysfunction in either group, and the frequency of LVH was relatively low in both groups with no difference in LV mass index. So on the basis of these preliminary findings, excitingly, we've just received further NHLBI funding to carry us up to 2025, in which we will conduct a 1,200 patient study of asymptomatic people with HIV, and it'll be powered to determine the prevalence of asymptomatic structural and functional myocardial abnormalities and the precursors of heart failure, and explore patterns and prevalence of fibrosis and steatosis. Furthermore, we'll investigate the role of inflammation, immune activation, and activated monocytes involved in this pathway of myocardial injury. Furthermore, we'll be able to explore the impact of traditional cardiovascular risk factors such as hypertension, dysglycemia, and take a closer look at whether or not antiretroviral regimens play a role. So, to summarize and conclude, HIV increases the risk of a spectrum of cardiovascular diseases. In the ART era, the risk of heart failure is approximately double that found in age and gender matched controls without HIV. Heart failure with preserved ejection fraction has become the dominant phenotype in the ART era, although heart failure with reduced ejection fraction is still important, particularly in areas such as sub-Saharan Africa, where the uptake of antiretrovirals is about 80%, and people start their antiretroviral therapy quite late. Amongst those without coronary artery disease, myocardial steatosis combined with fibrosis may play an important causal role in the pathogenesis of these heart failure phenotypes. With that, I'd like to thank you for your attention.